So I was talking about the brain death. Okay, so this special, did you understand who was the brain dead? These are the guys who had an accident and he has a brain injury, but he was lucky enough. He was intubated just prior to his brain activity cease, and but later his brain activity is gone. You do the lots of tests, brain activity test, and accident. So after all the tests, then they have this is brain activities, and they are declared brain death by a neurologist. Okay, so it means their brain will not come back. Okay, they are permanently dead. Okay, and so we have lots of bunch of tests to prove that, and after only then we can uh, prove that the person is brain dead, and we try to transplant them. Okay, so in the different types of organ donor, living, related, and cadaveric donors. I already told you. And transplant. There are a few things you should know. Okay, like immunological things are important. And when you say immunological things, let's suppose I need a kidney. I cannot just get a kidney from anyone. Okay, I can just pick any person in the street and get that kidney to me. It will not work that way. Before people tried that way, but it did not work. So later on, we have realizing that there are lots of antigens and antibodies you have. Okay, because we all has everything. Like foreign body, the foreign protein, anything is act as an antigen. Okay, and then antigen has already preformed antibodies. Okay, so it means we have the antibodies. Let's suppose we have a blood group. Okay, I am a blood group A and you are a blood group B. Okay, so I cannot take your blood, I take your organ, and we cannot just transplant your organ to my body. You know why? Because when I say I'm a blood group A, I have A antigen in my blood, but I also have a B antibody. Okay, so if you have a B blood group, you have a B antigen and A antibody. Okay, so what will happen? I have a B antibody. Okay, you have a B antigen. So there will be a reaction. Okay, so it will reject immediately. So in the blood group, which one is the lucky guy? A B, or O? Which one is lucky guy? Who can take
AB.
anyone's blood or anyone? Yes, AB, because
AB
AB
cell.
does not have any antigen. Okay, sorry, he has a antigen and B antigen. So, but he has no any antibody. So if you have no antibody, you will not reject it. Okay, that's why AB is the lucky guy. So AB can receive anyone's organ. Okay, so if you are among you, if you are a AB, remember you can take anyone organ. Okay, you are a lucky one. Okay, but if you are unlucky one, who is the unlucky fellow among them? It was the O. He
O
can
negative.
give because negative in organ there is no negative or positive. Okay, this doesn't matter. Although in the blood transfusion, RS typing is important. Blood organ transplant, negative and positive RS typing is not that relevant. So the O blood group who has no antigen, but he has the antibody to everything. He has the A antibody, B antibody, and it will react. If you have an antibody, it means you already have the machine gun to fire somebody. Antibody is like you are already preformed some kind of soldiers in your body. So whoever comes, it will attack. Okay. So if you have a AB, I mean O blood group, you can donate because you have no antigen, so you can give to anyone, but you cannot receive aside from O. Other, you cannot receive A or you can receive O. Okay, or AB. You cannot receive A, you cannot receive B, or you cannot receive AB. Sorry, you cannot receive O. Sorry, I confused. If you are a O, then you can only receive from the O. Okay, because you cannot receive because you have already preformed antibodies. You have no antigen, but you have antibodies. So the lucky blood group is AB. If you have a AB blood group, you can take any organs from anyone. If you have a O, you are lucky in the sense that you can donate it. Everybody will love you, but they will not give you any organs. You cannot. You only need that O blood group. Okay, that's the blood typing. Although we have started doing a transplantation ABO barrier. Okay, it means now we have the capacity to transplant even A to B or B to A also. But to do that, we have to really knock you down by giving a very strong immunosuppressive. Okay, you have to knock you really down so that you can only do not reject it. So it will be more costly, and we have to clean your plasma. We have to do a plasmapheresis. We have to give you IVIG. Because of that, a lots of procedure needed, and it's expensive, and it will your immunology is very knocked down, and the outcome also not good. Okay, because you have been giving a lot bombarded with a lot of immunological immunosuppressive medication, you might develop infection. Okay, so that is also one thing. So and there is one thing I think in during the transplant, I think you should know we all human have antigen, okay, genetic antigen. We call this human leukocyte antigen. Have you heard about this HLA antigen? These HLA antigen are detected on the surface of white blood cell, regulates how the body recognize and reject the foreign tissue. Okay, there are 5 loci with 2 antigen in each locus. Okay, and we call this A, B, C, D, R, and the goal is to match as many antigen as possible. एन्ड यो के छ भने यसमा चाहिँ यो एचएलए एन्टाइजिन भने के छ भने सबैमा हामी हुन्छ के तिमीहरुमा पनि हुन्छ ममा पनि हुन्छ सबैमा हुन्छ है एन्ड द मोर वी हैव मैच द बेटर द आउटकम ओके लेट्स सपोज देयर इज अ सर्टेन टेस्ट वी कैन डू इट टु मैच द एन्टाइजिन द मोर वी हैव मैच द बेटर द आउटकम ओके so we call it HLA antigen. So there are certain things we call is transplant rejection. Okay, like there are a hyper acute rejection. There are 3 kinds of rejection: hyper acute rejection, and chronic rejection. So let's suppose I am doing a kidney transplant, and during the operation, after I open the clamp, after I anastomose the arteries and vein, and after all these things, once I see the organ, it's started bluish. Okay, it means it is gone into the hyper acute rejection. Nowadays we don't see that one because this hyperacute rejection happens if you do transplant among the different blood group or maybe a different species. It immediately the antibody will attack and the kidney, the organ will damage. Okay, and another one is acute rejection. Acute rejection, the hyperacute rejection happens minutes to hour. Okay, but acute rejections can happen. You have the days to weeks or months. Okay, it is mediated by T cytotoxic lymphocyte. Okay, and the chronic rejection occur over time, long time, over time. Okay, chronic rejection over long time, and the signs are like pain at the transplant site, like feeling ill, flu-like symptoms, fever, weight change, swelling, and decreasing urine output. All these things can happen. Okay, so there are immunosuppressive medication. As I told you a while ago, cyclosporine is the game changer. In 1973 or 70s, it was invented, and because of that one, before we used to transplant one or another one, it did not work because there is a rejection. So once the introduction of cyclosporine or steroids, we are able to successfully do a transplant, and after that transplant really pick it up. Or maybe it's around 30 to 40 years only transplant started picking up. Although people have tried a lot of times before, but it was not successful because of the rejection. So after the introduction of the immunosuppressions, it was successful. So now we have lots of immunosuppressive medications. We have corticosteroids. We have your monoclonal antibodies. We have polyclonal antibodies. So lots of things are there. Every day there is new list is coming up. Okay, and we have a calcium inhibitors, which is the most effective immunosuppression, which is cyclosporine. Now we have tacrolimus also. We call this one, and it will help effective immunosuppressions. It prevent the cellular attack. Okay, avoid graft rejections. Okay, and also corticosteroid also very effective. We use a lot of steroid during the transplantations. Okay, and also we call it mycophenolate mofetate. That's also another immunosuppression. Monoclonal antibodies also. Okay, I will provide you this slide so you can go over all these things. Okay, so specific organ, kidney transplant. We have a liver transplant. You have a heart transplant, lung transplant, pancreas transplant. All these things. Okay, and I think I will take this transplant topic with you in person. It will be more interesting. Okay, I will take you during your fourth year, or maybe if you have time when you meet again, maybe in person it will be more interesting to talk about this. So basically, I think I want to summarize what we see is transplant is just getting a one one organ from auto transplant one person to allo transplant different person, right? And it has a different component. One is the surgical component, another one is immunological component. Okay, and so many things are here, and it is an emerging field. Now we are working on the xenotransplant, but we have not able to master the immunological balancing. Okay, so maybe later on the xenotransplant will be, or maybe we can uh, organ make an organ which is out of a lab, and we can transplant it later. I think that's the future going on. We can develop an organ in the lab, and which is suited to your genetical identically, and we can transplant it. I think that's our ultimate goal. Maybe in your lifetime, I think that is possible. People are working on that. Okay, so that we don't need to get any organ from any animals or another human beings, so that it will be easily reproducible. Okay, so these are things, exciting things in transplant field. And I'm as a kidney transplant. Maybe when you are in a clinical rotations, you can ask me questions. Maybe you can, if you want to watch it, you just ask me special permission, I can give you. So you can, we will start around 7 o'clock early morning. You can join if you like to see one. Okay, okay. I think I will wrap up my class here, and I will not take any more questions. But if you have any questions, just text me, and I will provide you these slides, and you can go through it, and I think it will be helpful for you. Okay, okay. Can we stop it now? Hello,
Yes, sir. Answer, sir.
Yes, sir.
hello. Anyone? Okay,
Yes, sir.
okay. So we'll meet again. Okay. I bye 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 bye.
Thank you, sir.